the lower limb cases are there. So overall the conference is on upper limb. So this is a case of management of critical bone defect in lower limb using Siliguri technique. I am Dr. Aniruddha Sinha. I work in Kuch Bihar. So I am presenting few cases. So this is a case of a 27-year-old male had an RTA, two-wheeler RTA, and this is the kind of wound he came to us with, and there was a open fracture. He presented 12 hours after the injury, and he did not have any comorbidities. So he was operated within 4 hours of arrival. Debridement was done, and bone names were fashioned for better docking after bone transport. External fixator was applied. Wound was closed. So this is after 3 weeks. And the wound was healing with dressing itself, and we don't have any classic surgical facility at our town, so with dressing only this wound was healing well, and the bone loss was 17 centimeter, which was healed. So we planned for Siliguri bone transport. So I initially planned for bifocal transport, but we had to do unifocal because during the proximal corticotomy there was posterior comminution, and we could not do the transport from that segment. So this is during bone transport. We can see that the transport segment, it is the region is forming well, and there is no deviation or angulation or translation of the transport segment. And there was minimal pin tract infection. On and off, it can be there. So after dynamization, we removed the fixator at around 15 months. So this is just after the removal of the fixator. So this is after removal. We can see that there was negligible limb discrepancy. There was no infection. The knee range of movement was good. It was around 120 degree, but ankle stiffness was there. So this is 2 years since the injury. The patient can walk. I mean, he has some limp, but he can walk, and there is no pain. And also the region has consolidated pretty well. Okay. So I move on to the second case. So this is another case of a 27-year-old male, also a two-wheeler RTA case, had a type 2 open comminuted shaft femur fracture with articular extension, and he presented 4 hours after the injury. No other injuries and comorbidities were there. So on day 1, we planned for Siliguri bone transport. So we planned for a 4-ring Siliguri construct, and we applied 2 rings in the proximal femur segment, 1 ring at the distal femur segment, and 1 ring at the proximal tibia segment. And there was a distal articular fracture which was fixed with a 6.5 mm CC screw. So we did waited for 3 weeks to do the diaphyseal corticotomy for bone transport, as we wanted the tissue to be quiescent before the transport. So distal edge of the proximal fragment was made transverse at that session to aid better docking later on. Bone transport started with a latency period of 7 days. Partial weight bearing was started. So this is during the transport time. At that time, the patient had we encouraged to do knee movement at home. We taught the attendants to do the knee movement. And this is at 6 months after the bone transport was started. The transport segment is docked with the distal segment, and now we plan for the next surgery. So we plan for fixator removal after stabilizing the regenerate, and with iliac bone grafting and distal femur LCD fixation. So the pin tracks, we ensured that the pin tracks were dry, and there was no infection. 1 week prior to the surgery, we started him on prophylactic oral antibiotics. So this is during the second surgery. So this is the leftmost image. You can see that we put the other leg in the lithotomy stirrup so that we could have a very good view of the femur, both in AP and lateral view. And we stabilized the transport segment with the proximal segment with the X-fix, so that the transport segment, it doesn't move and cause injury to the degenerate. And we put the distal femur locking plate. So this is 2 years follow-up since injury, and we can see that there is good union noted, and also there is negligible, some amount of very negligible limb discrepancy was there. So at 2 years follow-up since injury, the patient is doing full weight bearing walking, 1.5 centimeter shortening is there, but there is no signs of infection. Despite patient underwent early knee ROM exercises, patient now has stiff knee with only 0 to 15 degree ROM. We have plans for future quadriceps plasty after total consolidation. One more case is a two-wheeler RTA, another case, 47-year-old male. It was a type 3B open both bone leg fracture, initially managed and with abdomen X-fix and followed by SSG at a different center, and came to me 4 weeks later with X-fix on. There was no comorbidities. Patient also had a ipsilateral closed femur fracture, which was operated by the previous surgeon. There was 3 centimeter bone loss. There was a non-viable bone at the open wound. There were segmental comminuted fractures, fractures extended to the distalmost part of the distal tibia, metaphysis. Even after SSG, soft tissue coverage was not good. So we did a transport in this case to make up the gap. The proximal bone fragment was cut transverse to ease of future docking and also exposed viable components. This is the corticotomy, and after bone transport has been started. So you can see the regenerate forming well. This is after the docking, and this is at 11 months. You can see that the union has taken place, and there is some amount of translation of the distal segment, but there is no major deformity. So to summarize, I'll just skip this slide. That the fixator index was in the first tibia case was 26 days. In the femur case, where we applied the distal femur plate, the fixator index was 19 days per centimeter, and the last case it was 82.5 days. There were some on and off complications are there, but they are manageable. All the patients are walking, and there is no infection. So to conclude, bone transport is a promising method for managing massive bone loss. Elizarov is a more versatile fixator, and complications such as translation, angulation, or regenerate can be managed easily. Making the bone ends transverse leads to a better area for docking, and no further surgeries are required. LRS monolateral external fixators cannot be used in all cases, and lock plating after transport reduces the total fixator time and discomfort of patient. Other techniques such as transport over nail, transport with LCP with simultaneous external and internal fixator can be quite challenging if there is infection. And regular patient follow-up is extremely important in these cases. Joint stiffness is difficult to avoid. So these are 2 of my references. Thank you.